So we'll only discuss and test the three traditional methods of treating cancer. They are surgery, radiation, and chemotherapy. The oldest treatment is surgery. So back in the 19th century, when you have a tumor, all they could do was take it out surgically. Of course, what can only be taken out is the tumor along with a non-vital organ. So if it involves a vital organ, such as obviously the brain or the heart, can you take it out? No. Okay, so we can only have non-vital organs surgically removed. So that wasn't a very good option for some people. It's up to you. I can see. Okay, now as far as the type of surgery, or more like the purpose of the surgery, they can vary. So surgery can be diagnostic. Number one example here is a biopsy, which means it's used to diagnose the cancer. It can also be, I won't discuss the biopsy types. It can also be for treatment. I mean, the surgery is the main treatment. Now, treatment can be total, meaning you'll remove the entire cancer and that treats it. Or it can also be just debulking, meaning you're going to decrease the size of the tumor. Obviously, this would be an option for cancers that involve a vital organ. Let's say you have a brain tumor. All they can do is remove some of the tumor because we can't remove the brain, obviously. It can also be for the purpose of table 12-4 gives you different, more precise surgical options. Okay? I won't test table 12-5 though. Or 12-6. Okay? They can also be prophylactic surgery, meaning take for example what happened to Angelina Jolie. Okay, so she had the option. I mean, she has the money, so she opted for mastectomy. Okay, so she discovered that she had the risk for breast cancer because of her family history. So she chose to just have her breast removed and got new ones. Okay, so that's an option, prophylactic surgery. No, she's rich. She paid for it by herself. Okay, so examples of prophylactic surgery are those with polyps, for instance. Here, the polyps would be mentioned here. Polyps are usually discovered during a routine colonoscopy, wherein we, once we see it, we remove it right away because they've been known, it's not 100% sure, but they've been known to turn into cancer. So if they're discovered, we don't wait, we take them out. So that's example of prophylactic surgery. I have no idea. No. Yes. Polyps in the colon. Palliative surgery is exactly what it is. Now, when you hear of palliative, don't think of end of life because it's not always for end of life only. Okay? Palliative surgery can be done at any stage of the cancer treatment. Okay, whether you're at end of life or still at the beginning stages. So palliative surgery is any surgery used to improve symptoms. So let's say if the size of the tumor is so big that it's causing pain, or let's say it's in the brain that's causing seizures, then to get rid of the seizures and to improve pain, we do surgery. Okay, so we reduce the size. Okay, again, any surgery for this purpose is called palliative. Now, it's not only for pain, it can also be used to improve function. So let's say you cannot talk or chew because this tumor is right here in your gums. We take it out. Palliative doesn't cure you, but allows you to chew or talk or swallow. Okay. Reconstructive is to improve the image. Examples here is we'll give you a new breast. Okay, so let's say you lost your areola, you lost your nipples due to breast surgery, okay, or you lost your breast, so we can give you a new one. Okay, we can create a new nipple, okay, a new areola. Okay, so to reconstruct it. So let's say also your legs. Okay, so let's say your leg was deformed. Okay, we can you'll be referred to a plastic surgeon. Okay, they can fix it. Okay, improve your appearance. Now, for nursing management, is it any different from what we discussed already in chapter 16, post-op care? No, this is just another post-op patient. Right? So there's really nothing special. So same complications, pain, nausea, vomiting, same wound complications, same high risk for DVTs, high risk for pressure injuries. Okay, so we won't repeat that. Any question on surgical option? Very good. Let's go to radiation. There are two types of radiation here. We have internal and external radiation. The most common is external radiation. When we say external radiation, the radiation source, when we say external, obviously is outside the body. Now, most common example is radiotherapy, meaning the patient goes to a treatment center, say at Memorial Sloan Kettering, MSK. So they go to MSK to get radiation. The radiation is inside the treatment room. The radiation technologist or the radiation oncologist wears an apron, okay, takes care of you, and then goes behind a door or a wall, and then exposes you to radiation, just like an X-ray. Of course, this will be way longer than an X-ray because you're only exposed to X-ray for a few seconds, right? Or sometimes 2 seconds, and then it's over. This one is used for treatment, so it'll be a bit longer. Yes. Sorry again? Anyone exposed to radiation? Yes. So the concept of using radiation is to let your cells, of course, this will not distinguish between normal and cancer cells. All cells will absorb the radiation. That's already calculated. Now, the dose of the radiation is determined by 3 factors: time, distance, and shielding. Time, how long were you exposed to the radiation? Distance, what is the distance? How many feet or how many centimeters are you from the radiation source? And then finally, shielding, which parts of your body were shielded from radiation? You've all had x-rays, right? Let's say for your teeth, for instance, you go to the dentist or for a chest x-ray, for whatever reason, you were asked to wear an apron, correct? To protect other body parts, okay? Because you don't need the entire body exposed to the radiation. So that's an example. So that takes care of the shielding, meaning you have lesser radiation dose because you covered some parts of your body. Does that make sense? Mm-hmm. Okay. So those are the 3. So that's the external radiation. So the radiation source again is from a distance, usually a few feet away, or it can also be close. It could be 1 or 2 feet away from you. But the fact is the radiation inside your body? No, it's at the treatment center. You're exposed to it during treatment days, and then you go home. Okay? But your body did absorb the radiation, right? However, because the radiation source is external, yes, cells absorb the radiation, but not your body fluids. Does that make sense? Okay. So you go home, you are not radioactive. Okay? You were exposed to radiation, but you will not re-expose people around you to radiation because you did not bring it with you. Okay? Only your body was exposed to radiation, your cells absorbed it, but it will not enter body fluids. It can't. Okay? Any question on external radiation? All right, let's go now to internal radiation. So we already discussed dosage. Let's go now to the, okay, so that's external. So the correct technical term is external beam radiation therapy, okay, EBRT. Let's go now to brachytherapy. Internal radiation is called brachytherapy. Brachy means near, and then therapy, treatment. Okay, so the concept of internal radiation is we're going to put the radioactive material inside your body. Now, there's two ways to do this. You either get what's called sealed radiation. When we say sealed radiation, it's in a pouch. It's in a container. Okay, something is used to encapsulate the radiation source. It could be a sack, a pouch, a plastic cloth, whatever. Okay, they could also be applicators. Okay, so there are many ways to put the radiation source inside you, but the concept is we can take it back out. You understand? Mm-hmm. This is internal, however, it is sealed because we have it in a container. We have the ability to take it back out after the therapy is finished. Does that make sense? Okay, so that's sealed radiation therapy. So that's internal radiation, however, it is sealed. There's also an unsealed method, meaning we either let you swallow it, we inject it to you, or we put it inside a body cavity. Okay, so let's say we inject it into your bladder, put it into the ventricle of your brain. We put it into inside your thyroid is an example. You swallowed it, right? So for radioactive iodine, you swallow that. Okay, so any type of unsealed radioactive therapy will therefore enter body fluids because you swallowed it, okay, or it was injected to you, or it was put into your cavity, in your body cavity. So which means, can we take it back out? Yeah. No, because it's already inside your body. Does that make sense? Yeah. So therefore makes your body fluids radioactive. So what body fluids will become radioactive? Okay, anything wet, with the exception of tears and sweat. Okay, so only tears and sweat will not be radioactive. Everything else coming out of you that's wet, feces, urine, reproductive secretions, saliva, mucus are all right. So GI contents, they're all radioactive. Yes. Hyperthyroidism? Yeah. Yes, and I mentioned that. Yeah, RAI 131. Yes. Yes. So the precautions here, usually 2 weeks or longer for the body fluids, is applied to people with unsealed radiation therapy. So it's unsealed because the radiation dose is lower, and it's sealed because the radiation dose is higher. Okay, so just think about it that way so you can remember the distance and time that we use as a precaution. So if it's sealed, meaning it's higher dose, so how far can you safely stay from the patient? 6 feet, because it's sealed, it's higher dose. So farther, which means 6 feet. And how long can you spend with the patient? 30 minutes. Now the time here is total for the day. Okay, this is daily exposure, meaning don't spend the entire 30 minutes at one time. So you make sure that you only expose yourself as necessary, meaning if you're going to prepare the medication, do you have to prepare it 3 feet from the patient? No, you can stay 10 feet away. The patient has no business watching you prepare the medication. So you only go within the unsafe distance, because can you administer an IV drug from 6 feet away with a selfie stick? No. Okay. So you have to, okay, but whenever you are that close to the patient, you have to wear proper shielding. Okay. So where would you put the shield? I know where I'm putting it.
My breast.
Okay. This is the most important for me.
And then, yes.
Right
going
here.
down.
All I want to protect.
Your abdomen.
A bit lower.
Belly button, of course.
Yes. Thank you.
Your pancreas, for real.
What about the unsealed radiation? So this is lower radiation dose. So therefore, can I
An
stay
hour.
closer? 3 feet, and I can stay up to an hour. Okay, again, distribute the time. Okay, do not spend all your time allotted at once. Okay, stagger it out. In the same principle, should multiple patients be caring for these patients?
No, no, limit.
No,
the amount of-
limit the amount of staff, meaning, can you take, do you know how to take vital signs?
Yes.
Can you say, oh, that's not my job? The
No.
CNA must take the vital signs.
Uh-uh.
No, you're in there already anyway, so spare your CNA. Okay, so you're in there exposed, you have the shield, take the vital signs while you're there, all right?
So for both of them, it's 2 weeks minimum that they need to be.
Yeah, about 1 to 2 weeks, yeah. But to be safe, of course, I would go 2 weeks.
Oh, for both.
So for the unsealed, again, like I said earlier, they can be, implanted by any of these means, okay? But the whole concept if it's sealed, can we take it out?
Yes.
Yes, we have the ability to retrieve it. If it's unsealed, impossible. It's already absorbed.
What's
Or,
an example of that?
well, an example of which one?
The seal. I know
Okay,
for
the seal.
seal.
Okay, the seal can be like put into a tea bag
Mhm.
with a string.
Mhm.
Okay, that's usually the case for, let's say, cervical radiation implants. So we put it in there like an IUD. Okay, so there's a string which we can use to pull out the radioactive material. Or it can also be in the breast. Let's say in the breast, you've seen edible arrangements.
Mhm.
We have sticks that we have the fruits on at the tip of the sticks. We have something like that. So we have a bunch of sticks with radioactive seeds at the tip. Then we shove it up the breast. So there's an incision here where we took out the tumor. And then we want to finish off any remaining cancer cells there by putting that radioactive material in there. Okay, so we have an applicator, we have sticks here sticking out, we tape it, and the patient goes home with it.
So my next question is, so this as opposed to the one from like the external, like the internal one?
Yeah,
is
because the
the-
external has so much collateral damage. I mean, it'll burn your skin, so many things get hit. But again, it depends. What is the type of cancer you have? We're not the ones deciding. Okay, it's the radiation oncologist that decides whether you get internal or external beam
Because I'm
therapy.
thinking, like, if it goes in your circulation, then it's still going to go everywhere,
For which one?
like the internal. Like
Which one? The sealed or unsealed?
The unsealed.
Oh yeah, unsealed definitely enters your body fluids
Yeah.
because it entered body cavities and you swallowed
Mhm.
it or it was injected to you.
So wouldn't
Sorry?
it be like as toxic as?
Say again?
What makes it sealed?
Because again, it's in a pouch. Okay? The pouch will prevent it from coming out, but it will still emit radiation
Oh, so the radioactive.
because it's radioactive. Yeah.
Stays in the container.
Yeah, so only the immediate surrounding tissues, let's say a few inches from it, will be radioactive.
The other question that you said, this inside the breast, that it's the same time when the extract or it can be happened later.
Say again, tumor.
But it's like, if it's breast cancer,
Mhm.
so, and you said it's like inside the breast. Is it at the same time when the surgery performed?
Yeah, usually, let's say, because let's say we remove the tumor, yeah, from the breast. So there's a space left there. So we can put the radiation in place of that, the space, the cavity that was left by the tumor. We can put the radioactive material in there. And of course, after it heals, the space, of course, gets smaller and smaller. So eventually we won't need it anymore.
Then we do it after the surgery, like in 3 months.
Recut them again.
Yeah. So any question on radiation? Yeah, sometimes it falls out, accidental. Okay. Let's talk about what happens if they fall out. Obviously, which one will fall out, the sealed or the unsealed?
Wait, the seal.
Okay, only the seals can fall out, okay? Because again, the unsealed, it was already absorbed, okay? So for the sealed radiation, they can fall out. So what do we instruct the patient to do if they do fall out? Don't touch it, okay? Leave it on the floor. You can only handle it with long forceps or with special gloves, okay? Not your disposable gloves. Those things won't protect you, okay? So these can burn, okay? These radioactive materials, you've heard about radiation burns, right? Okay, so that's possible. So they can only be handled with long-handled forceps, okay? And then put into a lead container to protect people around you. Ah,
That's my.
they'll be provided with that. Or you can call your mom.
Oh boy.
Yes, there are toxicities, and we'll talk about the complications of radiation shortly. Okay, what are those complications related to toxicity? Meaning your normal body tissues have absorbed too much of the radiation, so they can come in the form of dermatitis. Now, these are very painful. Okay, these will literally look like burns. The skin will be very raw, red, wet, angry looking, okay, very tender to touch. This was and there's desquamation, meaning you literally like peeling, okay? You're peeling, and again, it's very wet, it's very raw. You seen, have you had sunburn? Wherein a wet sunburn, the blisters popped? Yeah, kind of like that, very painful, yeah? Okay, so it's like that. Huh? From what? Yeah, same thing. Yeah. So it's really it's really painful. Okay. That they don't want anything on it, like they even dressing or clothes. Okay, very painful. Here, dermis is exposed, skin oozing, serous fluid, very, very painful. This used to be the case with external beam radiation, but it has come a long way. Now they're able to control the trajectory plus the dose of external beam radiation. So we're having less and less cases of radiodermatitis, but it's not totally avoidable. Okay. We try to with again more precise radiation. Plus we have CyberKnife now. We have cyber, which is a form of radiosurgery. Okay, so it's radiation, but very precise radiation. Okay, they can target only the prostate, only one testicle, for instance. Okay, very, very precise radiotherapy. So the external radiation is much better now. We do have other means to do it to decrease radiodermatitis. One is we have fiberglass molds, meaning to make sure you assume the same exact position every time you come for treatment. We make a body mold of you, okay? And we put that fiberglass body mold on you to force you into that same position. So let's say the position, let's say it's on the head, right? So after they made measurements, the exact position has to be like this, okay, on the table like this. Can you remember this next week? No. So what we do to make sure you assume exactly the same position, we're gonna put a mold over your face. So they'll put the liquid mold. Then once it hardens, they'll make a fiberglass mold out of that and put it on your head every time you come in. So you're forced to assume exactly the same position. Okay, so very little radiodermatitis as a result. Okay, I mean, it's not zero chance of radiodermatitis, but we confine it to a very specific area only. Because let's say the tumor is behind your nose, it's in the nasopharynx. How are you going to deliver there without hurting your neck? Of course, it's going to burn your neck, right? So complications due to radiotherapy, remember, it hits collateral tissue, okay? We cannot like cut you open and then expose only the tumor. Of course, any collateral tissue in the way will be hit. Say your skin, the dermis, the organs, okay, or up over the tumor will all be hit. For example, here. So if it's in the head and neck radiation, will your salivary glands be destroyed? Yes, they're in the way. There also going to be ulcers in your mouth because they're hit also. Mucous membranes were hit. Okay? So as a result of losing your salivary glands, you'll have xerostomia, dry mouth. You have no more saliva. Imagine eating with no saliva. You put a piece of toast in that mouth, what will happen?
Staying right there.
Right. Okay. So I have a friend like that. Ironically, he was actually an oncology nurse, and he had this. When was it? Early 2000s, I would guess. Okay. So we kept in touch. He sent me pictures of his radiodermatitis. Like his was like here and all his neck here, very painful. Of course, he has some. What did we use again for burns? What was that ointment? Silvadene. Okay, so he used Silvadene for the burns. Okay, and he had to have a peg tube. For 6 months, he had a peg tube because he can't swallow. Okay, can't swallow. Plus, now it's dry. I mean, no sense, right? Eating, how are you gonna swallow? So he had a peg tube for 6 months. So mucositis are these really huge ulcers in the mouth. Okay, so imagine your entire buccal cavity, your mucous membranes in your mouth, all inflamed. Plus, you have the ulcers in there too, like ulcers this big. Okay, so that's mucositis, also called stomatitis. So there'll be swallowing and chewing problems, okay, anorexia, nausea, vomiting, and of course, poor malnutrition will result. So if these are anticipated, the patient will have just like my friend did, you'll have a peg tube ahead of time. So a few months before the radiation therapy, you'll be given a peg tube for you to practice, right? Especially people who are not in the healthcare field. So they get to, they learn how to use the peg tube before they actually have the treatment. There can also be bone marrow suppression here. So there can be pancytopenia. So for radiation and chemo, they really have similar side effects. So when we go to chemotherapy, there'll be the same side effects, okay, as radiation therapy. So when there's bone marrow suppression, this is the most life-threatening complication of radiation and chemo, because once you have neutropenia, what happens to you? High risk for infection. Once you develop infection and go to sepsis, can we continue the treatment? That's it. We can't continue with the treatment. You'll die if we continue with the treatment. So that's why priority for cancer patients, especially if they're receiving treatment, radiation and chemo, they have to be on neutropenic precautions. As much as possible, don't give them any rooming. Okay, they should be in a private room. And some hospitals aren't very sensitive to that, but you should advocate. This is your patient, tell your charge nurse. Charge nurse assigns a patient there, and then you look at it. Hey, this patient's infectious. You're putting them with this patient? No. Put them somewhere else. Okay, so you advocate. Okay, so be assertive. And if they question why, okay, tell them, okay, look at this patient, look at my patient's WBC count. Okay, or go to the doctor. Okay, ask your resident, hey, doctor, hey, but we have no rooms. They're about to put a roommate here. Okay, all right. You see what I mean? Okay, so advocate. Okay, because that patient, again, that could be your mom. Okay, that could be my mom, my sister, right, or my daughter, whoever. Okay, that patient deserves, you know, protection. Okay, and that's all up to you. Plus, they're at risk for bleeding. So you had your presentation last semester on thrombocytopenic precautions, HIT, right? DIC, so you're aware. So you know about bleeding precautions. And of course, neutropenic precautions, you know, no, nothing fresh or uncooked in that room, okay? No, avoid invasive lines, okay, if you can help it. And for anemia, of course, this will be a energy conservation, right? Because they don't have enough red blood cells, they will have activity intolerance. So these are the side effects, systemic side effects of radiation. There's fatigue. Okay? Sometimes we can explain it. We can blame it on anemia, but sometimes patients have normal blood counts, but yet they still have fatigue. Okay? So this is something strange we can't explain. There's fatigue both in chemo and radiation, which cannot be explained. And once you have fatigue, what's going to be complications from that? DVTs, pressure ulcers, okay, cardiac complications, respiratory complications, okay, because they won't get out of bed. And there are late effects. So late effects would include like dental caries, you know, because let's say if it's head and neck radiation, of course, it will destroy your teeth, okay? So you can have dental caries, you lose a few teeth from that. And depending again on the body part that was radiated. So if it's the abdomen, so you could have either complications of chronic diarrhea or chronic constipation. Can go either way. Or maybe you'll have both alternatingly. Okay, so the complications really is depending on which part of your body was radiated. Or let's say it's the abdomen or the pelvic area. So what will happen to the patient's reproductive function? May become sterile, right? They may lose fertility. Okay, same thing for the male patient, right? Or sexual dysfunction or incontinence, okay, depending again which part of the body was radiated. If it's the chest, could have pneumonitis, okay, could have pneumonia, for instance, or let's say pericarditis, okay. For the caregivers, no, including us, again, don't forget the apron whenever you come close to the patient. 3 feet, 6 feet, respectively, depending on if it's sealed or unsealed. But make sure you protect those around you as well. Contraindications to radioactive patients are, of course, pregnant nurses or pregnant caregivers. They should not be anywhere around these types of patients, or children also. So anyone under 16, no, can't visit. Another is if you are caring for this patient and you are, you know, all over this patient, let's say you're cleaning doo-doo, you have to wear a dosimeter. A dosimeter badge, because sometimes you forget, you know, how long we've been there. At least if you wear the badge, it tells you how much radiation has your body absorbed, okay? Remember though, the dosimeter, it's spelled D-O-S-I, meter, dosimeter, offers no protection. All the dosimeter badge tells you is how much have you absorbed, okay? How much have you been exposed to? Does not offer protection. Only the lead apron will protect you. Are we clear? Okay, protecting caregivers, again, anything wet. Okay, so use common sense here for, let's say this is unsealed radiation. So, you know, anything wet is radioactive, so can you share spoons,
No.
utensils? Okay, can you use the same towel? Can you use the same washing machine?
No.
But if, how many of us have multiple washing machines?
Oh.
We only have one in the house. Okay, we have to run, you can use it, but you have to run it empty.
Oh,
Yeah, after the patient's radioactive patient uses it with their own clothes, run it empty 1 cycle. Okay, make sure you rinse out the radioactive material and then everybody else can use it. Same for the bathroom. Okay. Again, some of us only have 1 bathroom in the house, so you may have to flush 2 or 3 times after they use it. Okay, make sure. And if it's they're incontinent, then of course dispose of the diapers or clothes properly again. Okay, so always just be conscious which clothing or materials were exposed to the patient's body fluids. Okay, so can they have sex? Not unless you can have sex from 10 feet away, right? So
totally.
last time I checked, it's impossible, right? Okay, so no sex for a certain time period. Any questions on radioactive treatment? Okay, let's go to the last one, chemotherapy. So these are using different types of medications. Some of these are antibiotics, some are anti-metabolites. Now on the NCLEX test plan, there's nothing there that says you're gonna be asked about chemo drugs. All it says is caring for patients receiving chemotherapy. Let me show you. So let me repeat, although we're not going to be tested on chemo drugs specifically, we are still obligated to recognize the drug, because the questions on the NCLEX won't say, patients receiving vincristine, a chemo drug used to treat breast cancer. Good luck. They will just say, patients receiving vincristine, and then they'll proceed with the question. All right, so how do you know what vincristine is? Okay, you have to know it on the list, okay? But of course, the question will not be about vincristine. It'll be adverse effects, because you know it's a chemo drug, so therefore, you know its adverse effects. Are we clear?
Yeah.
All right. Okay, there are so many drugs listed here. If you if you watch this video, it's interesting. Okay, this will show you an animation about how different types of chemo drugs kill them. So basically, all of the chemo drugs, whether it's an antibiotic, an anti-metabolite, an anti-DNA, anti-mitotic agent, they target the cell division process at different phases of the cell cycle. Does that make sense? Meaning, because if you remember the characteristics of benign and or malignant cells, what was the #1 feature? The cell division, okay? The multiplication, the growth was exponential. So therefore, will this type of treatment work on cancer? Yes, by interrupting the certain phases of the cell cycle. Now, will it only affect cancer cells?
No.
Unfortunately, just like radiation, this will kill any cell that is rapidly dividing. You're rapidly dividing. What are rapidly dividing cells in the body that are normal? Bone marrow, skin, hair, GI tract cells. So therefore, what will be the most common side effects for anyone receiving chemo?
Oh, hair loss.
Hair loss, anemia, thrombocytopenia, neutropenia, ulcers in the mouth. Okay. What else?
Weight loss.
Yeah, weight loss. Okay, because they have nausea, vomiting, anorexia. Okay, so it's easy to remember. Okay, just remember what are the rapidly dividing cells which are affected by chemo and radiation.
Physical cells and advanced stem parts of the body.
Okay, so you have a long list. There should be a table here.
Cancer cell, sensitive, rat- um, is it this, it's the exact same way that those cells which mentioned bone marrows and the same kind of,
Yeah, they rapidly divide. Like, have you ever, how long do your platelets live again? 7 to 10 days. So are they
Yeah.
produced rapidly? Yes. Red blood cells, 120 days, less often, and so on. Okay, your hair. How much hair do you lose in the shower? A lot. How come you're not bald? Exactly my point. Okay, so these are rapidly dividing cells. One thing you could be asked are signs and symptoms of extravasation, because the setup will be like this. If your patient receives chemo, you're not the one giving the chemo drug. So you'll call somebody. There'll be a chemo certified nurse on staff somewhere. And what they'll do is report off, meaning they'll have someone cover their patient assignment and then come down or come up to your floor, administer the chemo drug for you, and they'll give you specific instructions when to call them. This will be what's included, okay? Because chemo drugs are vesicant drugs that can cause extravasation. Extravasation is basically infiltration. But because these drugs destroy tissue, they cause severe tissue destruction, you don't want them infiltrating, all right? So if they infiltrate, what will they do to the tissues? Because if they're not running into the vein anymore, they're running into the tissues anymore because it infiltrated, they'll cause tissue necrosis. And once you have tissue necrosis, then the patient will require surgery to repair that, okay, to clean it, and it becomes a chronic wound. These wounds take a year, 2 years, or longer to heal, okay? Plus, the patient has thrombocytopenia, so there will be delayed wound healing as a result. So what are signs and symptoms? Okay, you have here well, they're usually burning, okay, burning, coolness, tenderness on the site, but most common complaint is burning, okay, and the area, of course, turns red and feels very warm to touch.
So it feels cool to the patient, but warm to you when you touch it?
No, it's burning, so it's not gonna be
Oh,
cool. Well, coolness to you.
okay.
Like if you look at the area, just like any infiltration, it infiltrates, so the solution is now in the tissues, not into the vein.
So it feels cool.
Yeah. So the intervention is easy. What do? Stop and then call the nurse. Okay, not the doctor. It's the chemo nurse that will take care of it. To be safe, chemo drug should be through a central line, a port, a PICC line, a tunnel or non-tunnel. But sometimes we started on a peripheral line, which is very dangerous. I only had this happen once, and it was the most busiest assignment because I was in that room every 10 minutes because it gives you, paranoia. Because what if, because if I make rounds once every hour, what will happen over that 60 minutes? Okay. And it's my watch, right? So if it happens, I cause harm, the harm happens to the patient during my watch. How does that make me look like, right? So I was in there every 10 minutes. Just literally parked outside my cow. I had a chair there and I was in there every 10 minutes. 10 minutes. The patient was just sleeping. All right, here are the drugs. So just be familiar with the names, right? So I'll pick a few names for the exam. You'll find out on the exam.
Oh, God, sir, that was like 50 just by that one stroke, please.
Okay,
And they don't all look alike.
then start looking at them. Here's a cue. If they're nothing like the lupus medications, if they're nothing like the what else did we discuss this semester? The Guillain-Barré drugs, the shock drugs, then it must be a chemo drug. How about that?
So in addition to the other 50, and you 50, basically. Or just don't learn.
I'm trying to help you.
Not meant to say,
Right enough, sir.
not-
Just be careful though, because look at the list.
Oh my
Some of them
God.
include, like, say, there is cyclosporins in here.
I know, because you said antibiotics. But we're not used to those. How about that?
First of all, cyclosporin is not an antibiotic.
Huh? No, I mean.
The
we're
hell
not
are you
used to
talking
any
about?
of these.
No, you do it. It's here. Cyclophosphamide. This was used for immunosuppression also.
Nitrogen mustard.
Right.
All jokes aside, as you said, specifically the glucocorticoid, the rheumatoid arthritis medication, all those, immunosuppressants.
Oh, they're not here.
They're not there. So if we don't recognize
Yeah.
those medications.
But look at this. Hydroxyurea is also used in sickle cell disease. This was also used in. Oh, no, never mind. It wasn't in lupus. But hydroxyurea, I know, was used in sickle cell disease. All right, let's go to the complications. Like I said earlier, complications, toxicity, same as with radiation therapy. So will there be bone marrow suppression? Will there be hair loss or alopecia? Will there be the mucositis and the stomatitis? Will there be nausea, vomiting? All right, let's talk about CINV. This is not your everyday nausea. Okay, there are 3 types of nausea here. Now, the drugs we looked at under post-op care, remember? There was a table with different types of drugs under post-op, nausea, vomiting. You remember or no? Yeah, there was a table under post-op care. So go back to that table because it's not repeated here. So PO, is it PO? Post-operative nausea, PONV. Management is the same as CINV, okay? Because these patients have worse nausea actually compared to the post-op patient, because they have anticipated nausea, meaning they haven't started chemo yet. They're already nauseous. They have acute nausea, and they also have delayed nausea, meaning up to 1 week after the chemo was administered, they're still nauseous. Okay, so they have, again, anticipatory, acute, and delayed nausea, vomiting. So will they be receiving one type of antiemetic? No. They'll have them all. Okay, so they'll have multiple antiemetic agents. Again, refer back to the post-op chapter. There's a table there with different types of, we had the serotonin antagonist, they had the prokinetics, they also had benzos there. They listed Valium, which is diazepam, in there, and there was also steroids there. Okay. Yeah, the chapter. There's a table there with listing all the medications. So I already mentioned anticipatory nausea. They have acute and also delayed nausea. Okay, delayed nausea, as already mentioned, could be up to 7 days after the last chemo treatment. So you have to know which drug to use. Okay, again, refer to the table under the post-op chapter. So these are the drugs we can add to the antiemetics. As already mentioned, these are also mentioned in that same table. So there were steroids there, phenothiazine, sedatives, Valium or diazepam, or antihistamines also. For the stomatitis, we usually give them a oral cocktail. The cocktail is composed of, well, it's usually saline, but the doctor adds benzocaine in it. You know benzocaine? Like Orgel. Okay, so there's benzocaine in it. There's also an antifungal in it because they already anticipate if you have mouth ulcers, then you're high risk for fungal infections. Okay, so you swish this. Sometimes it's swish and swallow. So if the ulcers are also in the throat, they'll swish and then swallow the cocktail, okay, to numb the throat, then they'll eat. Okay, so we usually give that 15 to 20 minutes before the meal, and then they can chew and swallow comfortably. So at least they were able to eat. Okay. So we talked about bone marrow suppression. So again, bone marrow suppression is called myelosuppression. When you have myelosuppression, then you have all three: neutropenia, thrombocytopenia, and anemia, collectively called pancytopenia. By the way, it's 3:23. Okay, let me explain the concept of nadir. Nadir is N-A-D-I-R, nadir. Nadir is not exclusive to cancer. It's also used in other forms of literature, let's say in literary work. You know, like poets use the word nadir. What is nadir? Nadir is a time period. What is this time? What is nadir in cancer? So the nadir in cancer refers to a specific time after and in between chemo treatments. This is the time where the patient's blood counts, the myelosuppression, is at their lowest level. That's what we call nadir. Okay, so let's say my heart is in nadir today. What does that mean? Yeah, my heart is at its lowest. Okay, because Michaela said no earlier. I asked her just to go out. Wasn't even the ring yet. She said, hell no. So my heart is in nadir. Okay, so you see the concept? Okay. So since the patient's blood counts, all three blood counts are at their lowest, should we give the patient any chemo treatment during the nadir period? No. Now, each chemo drug will have a different nadir. But overall, speaking generally, nadir is around 7 to 10 days after chemo treatment. Okay, average. Okay, again, each drug will have a different nadir, but so this is the reason why. Have you ever seen patients receive IV chemotherapy every day? It's usually every 2 weeks. Yeah, that's the reason, because of the nadir. Okay, we don't want to give them anything during the nadir period. So 2 weeks is between around the 7 to 10 day period. Yeah. Okay, so that would explain why the dosing is that far apart, because of the nadir. So what should we do during the nadir period? Protect the patient against infection, injury, blood loss, and of course, conserve energy. Okay, so they have anemia also. Now, to help them during the nadir period, we give them medications. So we have 3 sets of medications to stimulate the bone marrow. We have 1 set, which is erythropoietin. This will stimulate RBC production. We also have oprelvicin. This stimulates production of platelets. And not mentioned here is filgrastim, which is for the neutrophils. So filgrastim, Filgrastim, filgrastim. There's also a filgrastim, Filgrastim, filgrastim. There's also a long-acting version, which is pegfilgrastim. Just add peg to the word. Either way, both are for WBCs, but at least the pegfilgrastim is like a once a month thing. Okay, right, because it's long-acting. Filgrastim, you have to give that every week. Same thing for erythropoietin or epoetin alpha. This also once weekly. Oprelvicin also once weekly. The side effects are mentioned here. Okay. Take note, of course, because they promote the production of platelets and red blood cells respectively. So what should you monitor before giving the drug? Monitor the red blood cell count and the platelet count. Of course, if it's already normal or high, do you still want to give it?
No.
Especially if it's already high.
What about
They
blood
don't need it
pressure?
anymore.
What about blood pressure?
Well, again, same thing. So because epoetin alpha, for instance, because it increases your red blood cell count, can it cause hypertension? Yes, and increase blood volume also. So the purpose of these colony or growth stimulating factors is obviously to avoid blood transfusions. Why do we want to avoid blood transfusions?
Because you don't want to introduce
Complications, okay? Transfusion reactions, which are dangerous. Kidney damage, because those chemo drugs listed up there, most of them are nephrotoxic, so you should have to monitor kidney function. Oh, my mistake. Methotrexate is used for chemo as well. It is here.
It was in the chart.
And you still remember SIADH, yeah? Okay, so for brain cancers and therefore patients receiving treatment, radiation, and chemo for brain cancer can develop. Actually, both, or either one, either SIADH or diabetes insipidus. And for heart toxicity, meaning cardiopulmonary complications or side effects, adverse effects of chemo are the following. So they can have the pericarditis, as already mentioned, or dysrhythmias. And you still remember capillary leak syndrome, yeah, from sepsis? Okay, so these drugs, the chemo drugs, can also trigger capillary leak syndrome, meaning they'll swell. Okay, they'll have edema in the arms, legs. Most patients are advised ahead. Women of childbearing age, patients of childbearing age are advised to bank their eggs because chemo and radiation can cause infertility. Because are the reproductive eggs, cells also rapidly dividing? Yes, as long as you're menstruating, yeah, that means your uterus is, your uterine lining at least, are rapidly dividing. Same thing for a male patient. So they'll bank their sperm. There's something we know, a phenomenon called chemo brain. Chemo brain doesn't occur in everybody, but this literally is neurotoxicity, meaning the patient's IQ drops. But good thing is this is not permanent. Okay, it is reversible, meaning after you finish chemo treatment, you survive the cancer, your intelligence comes back. Okay. But literally, my friend, I use my friend as an example again. So after he got radiation and chemo, he had to stop working for 2 years because he had chemo brain. He could not recognize the names. He recognized the faces, but he could not remember names of his coworkers. Okay. And he was strange, he said, I finally, experienced what it is to have chemo brain. He deals with it with his patients, but he never thought, him as being a patient, they'll have chemo brain. He says, this is exactly what chemo brain looks like. Okay? He has brain fog. Okay, so he can't obviously perform at his best, so he asked for a 2-year break. He went on disability because of it. But he got his job back because he was good. You know, when he went back, he just gave his boss a phone call, and the boss said, "When can you start?" Yeah, it'll be the same for you. So if this, unfortunately, if this happens to you, you want your job back and you performed well, your boss will say the same. Okay? When can you start? Okay, so that's chemo brain or brain fog. Okay, fatigue, we already talked about. That's repeat from radiation. Let's go now to let's go straight to the emergency complications. So we'll skip the administering chemo. Again, we're not the ones giving this. It's the chemo certified nurse. If you're interested, it's only 6-month training, and you do need a BSN first, and then you go for 6-month training, and then you're a chemo nurse. Okay, and you get $2 or $3 per hour extra. That's a lot.
For
What do you
6
mean
months,
nothing?
That's good.
It's a lot.
$3 adult.
Yeah, that's per hour.
$3 adult.
Yes. See what I mean? Oh, sorry. Here, the signs are here. Okay, so remember I was just blurting out the signs and symptoms of extravasation.
Oh.
Okay, here it is. And you can read. So I'll let you read that. So what do we do again? If we see these, if we suspect them, okay, stop and call, yeah, chemo nurse, right? Don't bother with this first aid because the antidote is different for each drug. Okay, so sometimes they have saline, which is the you flush. Sometimes it's not, it's another drug. Or let's say some say cold compress, some say warm compress. Okay, so don't bother with what's your only role? Stop and call the people who know what they're doing, right? If you get a spill, because let's say you have a chemotherapeutic agent spill on your unit, there's a chemo spill kit. It's a bucket. You open the bucket, everything you need is in there. There's gloves there. There's cloth, cleaning cloths. That's what you use. Are we clear? Okay, don't do not paper towels. Okay, there's a specific equipment needed to clean chemo drugs. Okay, there's a chemo spill kit on every unit that administers chemo. So nausea, vomiting, again, refer to the post-op chapter, okay, for the drugs. But because we have 3 types of nausea: anticipatory, acute, and delayed nausea. So when are you giving the drugs, the antiemetic agents? Before, during, and after chemo. Okay. Up to 7 days after chemo. I'll do the stem cell transplant now. It's really short. I'll just describe that there are 2 patients here because the transplant, meaning there's a donor, correct? We had to get this stem cell, this blood from somebody. So somebody's bone marrow or somebody's blood was taken, and then we transfer it to the patient. Now, here's a safety for handling chemo, chart 12-5. Let me take you to the phases. Okay. I can't find it. Let me just describe it to you. Let's say I have leukemia and I'm going to receive bone marrow transplant or stem cell transplant. I have cancer in my bone marrow, correct? So what will happen if you give me somebody else's bone marrow with my cancerous stem cell still in there? What will happen? It's useless, right? Okay, so what should I receive before I get somebody else's bone marrow? I should be treated first. So the doctor, the hemo-oncologist will eradicate my bone marrow, like down to 0. So I'll be totally helpless. So during this period, what's my most number one risk factor? I'm gonna die from an infection because my blood count is so low. I cannot protect myself. So will I be in a semi-private room? No, I'll be in a private room. Okay. So everyone coming into my room will be dressed head to toe with PPE. Okay, because I'm very immunocompromised. Granting I survived this phase, okay, of the massive dose of chemo and radiation, I will now receive the bone marrow. Now, this bone marrow given to me has to be washed. By washed, I mean not under the sink. We remove it, we remove any active WBCs from it. So the doctor, the hemoncologist will make sure this bone marrow sample that they got is free of any active lymphocytes, okay? They'll take out any WBCs that are activated in there, wash it, and then give it to me. You know the concept of organ rejection, correct? Who rejected who? The host rejected the graft, right? Here, can I reject it if I'm severely immunocompromised? No. So what will happen if the doctor messed up? There was at least one WBC that's in there. What will happen to me? The opposite will happen. So that's what we call graft versus host disease. So now the bone marrow that you gave to me
Will attack them.
will attack me. All right. So what's the largest organ of the body? So most manifestations of graft versus host disease will be on the skin. So I'll look like a leopard. So I'll have some rash spots all over my body. Okay. And then the next thing usually is the liver. So the skin and the liver are usually attacked here. I don't know why the liver, but the skin definitely will be your earliest sign of graft versus host disease. So the only way to prevent this is, of course, wash it. Okay, should have been washed. But let's say, too late now. We already have it. So can I still be given anti-rejection medications? Actually, it will work. Okay, so I will be given anti-rejection medications and it will help with the symptoms.
So you mean every time you grab only because the bone marrow that was donated
Wasn't fully washed, yeah.
Seriously? Oh, that's wait. That's 100% accurate statement. I work on an oncology. I've seen
Most of the case, most of the time. I mean, I won't say, 100%. Of course, there are other factors to consider.
So you're washing, sorry. You're washing it to remove the.
Any active lymphocytes.
From the
The
graft.
graft, yeah.
Okay.
Yeah, continue.
Um,
Of course, there are other factors, but was just one example
the other factor,
during the
hurt the host,
the host immune system. How they react to we call this period engraftment.
Right.
Yeah, their engraftment period.
but I just find this, I just find it's hitting a little bit personal. I've seen it happen all the time, and they only say the patient's body rejected.
Could be true, but it could also be, they messed up. All right, I'll get you to the, what is today? It's the exam next week.
The following week.
Who took my picture? Okay, I won't keep you. I'll finish the 6 oncologic emergencies next week.
But what is the next?
Up to here.